Welcome. We're delighted to be doing this webinar on evidence used for policies and programs generating evidence. We have four areas we'd like to discuss in this webinar. Why do we need evidence? How is evidence generated? Levels of evidence, and then study designs. Why do we need evidence? Put very, very broadly, typically one would want evidence for evaluation of impact, cost effectiveness, advocacy. I'll use an example that illustrates each of these. In the next slide, I have picked the Lancet series on maternal and child health, the first one in 2008. And in the next slide, we see that through a series of systematic reviews, the Lancet series came up with very strong evidence for implementation in what are called 36 high-burden countries, implementation of interventions that would improve maternal and birth outcomes, interventions for newborn babies, and interventions for infants and children. In the same 2008 series, there also was a articulation of evidence for implementation in specific situations. So that was the evidence. Equally important, and in the policy community, in discussions in which I was involved, this was the evidence that really created a lot of buzz. The fact that not only did we have, for pregnant women, young children, not only did we have efficacious interventions, but we could quantify the number of lives saved, and we could also quantify cost savings in DALYs, which is disability-adjusted life years, basically healthy years, accounting for premature mortality and disability. And it was that powerful combination of the impact evidence as well as the economic analysis that really created a buzz in the community. And this led to, in the next slide as we see, Lancet Series 2008 produced the evidence. It was used as the key body of evidence for to the momentum for the scaling up nutrition movement. And research that Shivani and I have done in Nepal and Uganda, as well as the work in Ethiopia with Save the Children, the Lancet series was cited as a key piece of evidence in each of those three countries in developing multi-sectoral nutrition plans. Lessons learned. Evidence is important, but advocacy is key. Now, the reason I say this is I can point to a lot of research over the years, over the past 50 years, really rigorous, high-quality research that never was used. And I think the difference with the Lancet series and feeding into the scaling up nutrition movement was a fact that we had a series of champions for nutrition, and this is critical. The Scaling Up Nutrition movement was launched at the UN General Assembly meeting in September 2010. I had the honor of attending. But more importantly, there were high-level officials who launched it. Then Secretary Hillary Clinton of the U.S., Secretary Martin of Ireland, and basically the message from Secretary Clinton and Secretary Martin was, okay, basically advocacy is key. So the linking of evidence to advocacy is in my experience, the formula for success. And the message when SUN was launched is, we know a lot, let's put it into action. So the rest of the story. SUN, the Scaling Up Nutrition movement, has a two-pronged strategy: direct nutrition interventions, where the 2008 Lancet series provided a solid body of evidence. But the second prong of the strategy was nutrition-sensitive approaches. And the rationale was that in order to achieve agreed upon global targets, which Shibani will talk about in a minute, in order to achieve agreed upon global targets, we need both direct as well as nutrition-sensitive approaches. The following Lancet series, in 2013, so the second Lancet series, put more emphasis on generating evidence on nutrition-sensitive interventions. But despite this increased focus, there were still large gaps in evidence. And in the next slide, what we see is there have been a lot of meta-analyses of effects of, in particular, nutrition agriculture strategies. And in 2014, Patrick Webb and I did a synthesis of these meta-analyses, and I'd like to look at some lessons learned in the next slide. Here we review the individual meta-analyses that were done. I'm not going to go through each of the slides, but what's very clear is where you go from Ruel to Berti to Leroy and Frangillo, the kind of agricultural activities that were included in the meta-analysis varied. That's number one. Some of the meta-analyses were systematic reviews, some were not. The fourth column, number of studies retained for review, as you can see, were quite small. And if we go to the next slide, third one down, Massett et al. In 2011, of the 7,239 studies identified, only 23 were considered of sufficient quality to be included in the systematic review. And what's interesting in the Massett et al. Column, the last column, quote, we found no evidence of impact on prevalence rates of stunting, wasting, and underweight among children. I would purport that that's the wrong metric for looking at impact of agricultural evaluations. And I think globally where we are is that stunting is seen as quite a good indicator of overall development, but it's a quite reductionist point of view to look at an agricultural intervention and stunting as the outcome. As a result of the various impact measures for nutrition that were used, the conclusions or the lessons learned in the next slide from the Webb and Kennedy paper was the empirical evidence for plausible and significant outcomes remains disappointingly scarce. However, the absence of evidence should not be equated with evidence of no impact. And what we really need to do is what I call unpackage what is meant by nutritional status. The analysis of agriculture nutrition have used varying indicators of outcome, including nutrient density, diet diversity, diet as a whole, and that could be at household, at child level, anthropometric measures. And the measure that is used really needs to be linked to the specific agricultural intervention under study. Now, also we need to consider, and I think this has really been done from the point of view of the particular agricultural strategy or intervention, are we looking at a short-term versus a medium to longer-term metric? And that's critical. Now, the landscape has changed a bit, as we see in the next slide, where a year ago, the UN declared a decade of action on nutrition, and this decade of action is being championed by FAO and WHO with help from other parts of the UN system, as well as national level governments, as well as international NGOs. And what we see in the next slide is the 2017 Africa Nutrition Map. The large circles, and let's go to Ethiopia and East Africa, the dominant nutrition problems are still the classic undernutrition problems. But if you look at the triangles in many, many countries, what we see emerging is problems of overweight and obesity and chronic diseases. And those problems of overweight and obesity are increasing at exponential rates. So when the UN and others talk about malnutrition in all its forms, we're talking about undernutrition, micronutrient deficiencies, as well as overweight and obesity and chronic diseases. As a result of this, in the next slide, what we see is when you look at stratifying nutrition problems by typologies of food systems, and this comes out of the Global Nutrition Report, where they had 5 food systems going from, on the left of my slide, the industrialized food system down to the rural food system. What we see in the industrialized food system is very high rates of overweight in adults in the industrial, in the mixed, and transitioning food systems, much lower rates in the food system classified as rural. However, the flip side of this, when we go to the next slide, is that when we look at vitamin A deficiency, stunting, and anemia, the opposite finding from the prior slide, that you find in industrialized food systems very low vitamin A deficiency in children, low rates of stunting, and lower rates of anemia in women. So that food systems are associated with a different mix of nutrition problems. And this really speaks to the issue on the next slide of, in an earlier slide, I used the term unpackaged, really looking at the food system from the point of view of production all the way up to consumption, and what are the effects at each stage of this system, from production to storage to processing to retailing up to consumer behavior, in affecting the food environments. And the food environments is the actual context that the consumer faces in making food choices, and it involves factors like food access, food availability, food promotion, information, and quality and safety. And by unpackaging, we look at each part of the food system, where are points of entry for maximizing nutrition input. Let me give you an example on the production system. Maximizing nutrition effect or input might involve eliminating aflatoxin contamination. You'd have a different point of entry at the processing and packaging level. So you maximize nutrition input and you minimize nutrition coming out of the system. For example, storage, exchange, and distribution, minimizing post-harvest losses makes a contribution to nutrition. So really looking at the food system from the point of view of process indicators, which when combined lead to or can lead to a significant impact on diets and ultimately possibly nutrition and health outcomes. And with that, I'd like to hand over to my colleague Shivani Ghosh to talk about other aspects of evidence. Thank you. Okay.
Thank you, Eileen, and good afternoon, everybody. I'm just going to take the presentation to a different place, but just as relevant to what Eileen has been speaking. But before I go there, I think Eileen has set the stage to talk about, what are the global issues and what do the prevalences of the different nutrition conditions look like. So I think it's important to really just look at global nutrition targets for 2025. And these are a combination of the World Health Assembly targets, which are focused really on undernutrition, as well as what is called as the Global Monitoring Framework for Preventing and Control of NCDs. And as Eileen has mentioned, this is something that is really an emerging issue in many transitioning countries, emerging economies, as well as in developing economies. So you have very clear targets that have been set up for stunting, for wasting, for overweight, for anemia, exclusive breastfeeding, low birth weight, adult overweight, diabetes, and adult obesity. So the question that always comes to mind, whether you're in research or programming, is how do we track these targets? How do we know that we are achieving or not achieving these targets? And this is a table that comes from, again, I'm using the source is actually the Global Nutrition Report. This is the older one, which is the 2014 one. And not to go through this entire table, but what you're looking at here is the global progress against global nutrition targets as of 2014. And what you're seeing on the, basically the fifth column, which says on or off course, is that we pretty much off course on all the different targets. And this is these global numbers, obviously. You can actually, you might actually want to know what's happening at the country level, and this is where it gets very sticky. And that's really where I want to focus on in terms of data and evidence. One of the biggest issues is when you go to the country level is you may or may not have current data, or you may have no data at all. So what you're looking at here is a slide from Global Nutrition Report 2014, and I can assure you that this situation has not really changed as much. What you're seeing is the four major indicators of the nutrition targets, which is reduce stunting, prevent overweight, cut wasting, and half anemia. And I don't know how the colors are appearing on your end, but the dots that are appearing blue or it says no data, basically that's telling you that in the case of reducing stunting, 84 countries did not have data as of 2014. So we have no way of knowing whether these countries are actually meeting their targets or not. This goes also on the other spectrum of nutrition, which is prevention of overweight in children. 86 countries do not collect data that will even tell us what the prevalence of overweight is at that time point. So on. The only indicator that has data is essentially anemia. And you can see that the orange dots are telling you many of these countries out of the 193 that have ratified these nutrition targets are actually not on course. So that's something to think about, that we really, one of the big questions and one of the big comments that comes up in pretty much many applied nutrition and programming meetings is that we really need data at the global level and at the country level, and data that's collected on a regular basis for us to understand how these countries are achieving their targets or not. So I'm going to just shift gears a little bit and go in the direction of data for what, and go towards the idea of generating evidence and how do we generate evidence. So data is needed, as I mentioned, my first example was the global nutrition targets. That's basically generating nutrition information in the form of surveillance that will allow you to follow populations over time to see whether you're meeting your targets or not. Now, another reason you need data is to understand whether it's at the country level, at the subnational level, at a regional level, if the implementation of a policy initiative or one program or several programs are actually achieving their intended outcome. And that's sort of slightly different from the idea of doing an impact evaluation. So the second bullet really focuses on this concept of implementation research, which is not just if they have achieved the outcome, if they haven't achieved the outcome, why they haven't achieved the outcome, because it could be that there have to be certain tweaks that have to be made to the policy initiative or to the program. And in the fourth bullet, I put in what really is the focus of a lot of applied nutrition research, which is to look at new strategies and innovation. And these are obviously linked to generate evidence that is going to guide policy. But I consider this as a separate bullet in which you're doing studies that are testing efficacy or effectiveness of new innovations or new strategies that might eventually go down in the pipeline towards programmatic activities or policy initiatives. So irrespective of what your data is for and irrespective of the type of your study, there are certain basic elements when you design and implement a study. So it doesn't matter if you're doing a large national cross-sectional survey or you're doing a very small study in which you're following one community or three communities. The first thing is you really need to have a research question or an objective if it's a sort of national surveillance, and as well as a hypothesis as to what is it that you're trying to study. And obviously, linked to that comes the fact that you need to have an outcome of interest. So in the case of, and Eileen has pointed out that the idea of looking at stunting might be too reductionist, but obviously that is one of the indicators and outcomes of interest that a lot of nutrition-sensitive interventions and studies are using in developing their research question. The key element in trying to answer your research question and studying your outcomes of interest is the study design. And this is extremely imperative, and we spend very little time on really deciding what the study design should be. And even less time is spent on sampling strategies and sample size estimation. These are two very crucial points. We could go into each and every one of these, and we can have a long discussion about it, but there are really, really important things besides the research question and hypothesis is your study design, your sampling strategy, and sample size estimation. There are obviously statistical analysis that need to be conducted, and this idea of doing your statistical plan while you are planning the study is quite important because you may land up with data that you cannot utilize. And finally, obviously, you have study implementation. So just to drill down in a few of the elements of a study, you have the research question. There are certain essential characteristics, and some of the information that I'm using I'm pulling it out of clinical research, but I think it has a lot of relevance for programmatic research or for applied nutrition research as well. So obviously, you have to have a research question that is feasible, but at the same time, it has to be interesting and innovative or novel, as in it's adding to the literature. But you have to also keep in mind that it has to be ethical and relevant or worth doing. And the same thing applies in terms of your hypothesis. Your hypothesis is always based on your research question, and it should state very, very clearly what type of a relationship are you looking at, what population are you going to study, what variables are going to be studied, as well as what are you expecting, if, for instance, you're looking at an intervention, what is the difference you're expecting to see because of the implementation of that intervention. Most importantly, any statement that you write in a hypothesis has to be measurable. So this is just to give you, this is a list of different study designs that are used in the applied realm. And you have observational studies, and many of you may be familiar with the ENGEN birth cohort study. That was a prospective cohort study where we followed a group of pregnant women. And the outcome of interest was to look at the birth outcomes in their infants and to look at height for age at 12 months of age. So you're following people over a period of time, but it's an observational study. You're not implementing an intervention. So in this case, ENGEN was being implemented around this study. The study itself was not implementing any ENGEN intervention. You have cross-sectional studies. So the DHS, for example, the Demographic Health Survey would be classified as a cross-sectional study. And then you have what is called as a case control study, where you would have defined cases. Let's say you would really like to see what is the difference between stunted children and non-stunted children in a population, and then you would define the stunted cases and the non-stunted cases and do a measurement of one time point. I think many of you will be familiar with the experimental study design, such as the randomized controlled trial. You have also quasi-experimental trials, which are not randomized. They are usually non-random intervention assignments. In both cases, you will have a treatment and a comparison group, and you need to measure pre and post-test measurements, so you can do a comparison before and after. And usually the analysis is called difference in difference estimation. So this is just to give you a different schematic of epidemiological study designs. So it kind of puts it a little bit more in a pictorial sense of what the different designs look at. So the first one is really a cross-sectional design where the exposure and outcome are measured at the same time. So you have the only answer you can get out of this kind of a study is an association, that are these two related to each other. You cannot make any causal inferences using a cross-sectional design. The second one is a case control and a retrospective study. Again, you're not looking at causality here. These three designs are essentially aimed at looking at is the outcome related to the exposure, and you're doing it in different ways. So the central one is where you look at the outcome. Let's say you're looking at stunting right now, and you try to do a retrospective analysis, and this is very hard to do, and has less rigor, where you go back into the exposure. So if you had really good hospital data, for instance, you could determine if the stunted kids, what were their birth weights, if the birth weights were recorded. And in most cases, they may not be recorded. So this is why a retrospective study becomes really hard to implement. And then you have the prospective study where you follow a group of households or a group of women or a group of children for a specific exposure, and then you see what happens to them at a certain time point. So you're following them prospectively. And so what does that mean? And in just taking it to where Eileen was coming from in the Lancet series, there is a hierarchy of research evidence. So you have different designs, you have different methods you can implement a study. Those designs have to be really linked to what your research question is. But we know that systematic reviews, which are a compilation of different studies, are considered as the highest level of rigor. And I'm going to go into some of the first three slices of this pyramid so we can look at each of these and why these are considered at the highest level. So you have the systematic reviews, randomized controlled trials, and cohort studies. These are considered as the top three tiers of the hierarchy of research evidence. Case control studies are the next level case series. Usually these are done in clinical settings in a hospital when doctors are doing research and they write up reports. And lastly, you have editorials and expert opinions. And in this case, the author puts them at the bottom, but these are often allowing us to think about future research ideas because you have experts who have a lot of experience who are probably putting all the years of experience down into an editorial or an expert opinion. So I do not discount any of the lower tiers. I think they just help us build the case to do more rigorous research. So I'm just going to go through the first three layers. So the systematic review and the meta-analysis. Now, everybody is familiar with Lancet 2008 and 2013. And each and every paragraph in the Lancet 2008 papers that you will read, or 2013, so each and every nutrient that they reviewed, or every approach, or every intervention, the findings were based on systematic reviews and meta-analyses. So basically, if you had those 10 interventions, each of them had their own systematic review and their own meta-analysis. And so that's a lot, and a lot of different studies that were reviewed and compiled together. So that in itself explains why a systematic review is considered as the highest level of evidence, because you're able to bring together a lot of different studies conducted by different groups, which may have differing results, but you're able to come up with a common answer. Now, there are two things here to keep in mind. The systematic review is something that is a systematic way of reviewing published and unpublished data. In addition to that, you could utilize the findings of those studies and then do a meta-analysis, which essentially requires pretty advanced statistical procedures. So there are two different components to, so the systematic review can be done by itself. You don't necessarily have to do a meta-analysis. But generally, a meta-analysis is always done along with a systematic review. So a meta-analysis is essentially going to give you greater statistical power, and the conclusion is going to be stronger than the analysis of a single study. Essentially, it helps establish statistical significance if you have conflicting results. And in the case of zinc, for instance, there have been a lot of conflicting results about the relationship of zinc with linear growth. There haven't been a lot of conflicting results about zinc and diarrhea, treatment for diarrhea. So essentially, any meta-analysis or systematic reviews, if you read about zinc, you will find that there is absolute recommendation that you can go ahead and use zinc as a treatment for diarrhea. But you find very little evidence. The meta-analysis is not giving us the confidence to say that you should use zinc as a supplement for linear growth. It is connected to linear growth, but it is not currently recommended as an intervention. So these are some of the advantages and disadvantages. It's, as Eileen pointed out, and that was a very good example of the Lancet study, which they actually found 7,000 titles on their first review. And of that, by the time they had whittled down through and defined which ones were the highest rigor studies, they came down to 23. So 7,000 to 23, that's a lot of reading. That's a lot of, it's exhaustive to go through. And a lot of, usually these kind of research initiatives have a lot of graduate students, fortunately for that. But But they take time. The good thing is they're less costly because they review all the prior studies, and generally less time is required than if you have to just consider one single study. And they're more reliable and accurate, but they are very time-consuming as well. And as I've already mentioned about the meta-analysis, this is a very strong tool to bring together conflicting data and able to sort of say, okay, here you have 10 studies that showed no effect of vitamin A, and you have 15 studies that showed an effect of vitamin A. If you bring them together and use statistical methods, what is the net result? And does that give the confidence to the experts that then vitamin A supplementation is essential and necessary for children under 5 years of age? So that's just to give you an example. Each and every nutrient in the Lancet series has been reviewed and treated through meta-analyses and systematic reviews. And this is just to show you the different stages of a systematic review and a meta-analysis. This in itself is a separate presentation by itself, but I'm just sort of sharing it with anybody who might be interested. It's a very nice article that I've used here. And it's a small, brief article, but this author goes through and outlines exactly what you need to do a systematic review and a meta-analysis. Randomized controlled trials, I think, again, many of you will be familiar. This is where you randomly assign participants to intervention or an experimental group versus a control group. And the randomization can occur at an individual level or at a community level. Most of the work that we do in applied nutrition and in programmatic interventions is going to be at the community and the household level. So any of those studies will be called as cluster randomized studies. Now, a key element of a randomized study is that you need to blind people of the treatment that they're receiving, and you ideally should also be blinding the investigators so there is no bias generated. Unfortunately, that's not always possible, so you'll find a lot of the times that the blinding is single, where the participants are blinded from the treatments, but not necessarily the investigators. And again, there are advantages. This one of the biggest advantages, considered as the golden standard in nutrition research, because if you randomly assign individuals, communities, or groups to receiving treatment A versus treatment B, what you find is that you will have very little confounding. You will have very little effect of other variables outside your intervention variable. The disadvantages are it's an extremely expensive study to do. Most randomized studies require intensive monitoring of compliance. And there could be volunteer biases because people who agree to participate in the study might actually be interested in the study, and that creates a bias. And a key element, because we use RCTs, in applied nutrition and programming, we always consider RCTs as a way of defining causality. And in clinical medicine, they actually are concerned of the fact that may not reveal causation because of the heterogeneity within a population. So if you're dealing with a homogeneous population of, let's say, seeds or crops, it's very easy. You can definitely show causality. However, when you're dealing with human beings, each and every person, even whether you're within the same community or the same tribe or the same clan, each individual is different from the other in the way they react to treatments, to whether it's medications, to supplementary foods, to supplements. And so the concern that is, and this is a much higher level statistical concern, is that it may not necessarily reveal causation. And the last point is there can be loss to follow-up because intervention studies are over a period of time, you might have a loss to follow-up. And last but not the least, which is what we have done in the ENGINE program, is the cohort study where you follow groups. In this case, we followed pregnant women prospectively, and we did status evaluations every 3 months. And while this is on the third year, we've left the meeting. Are they on? Okay. Sorry. All right, because it just kept saying it's coming in and on. Okay. Sorry about that, everybody. I just thought you had left the meeting. So essentially, when this study is conducted, as you progress along, you're going to measure the outcome. And the advantage of this is that you can measure the outcome over periods of time, and you can have repeat measurements and will allow you to understand how the exposure is related to the outcome. So it sort of can be a very robust way of assessing the relationship of exposure to outcomes. I'm just going to skip over and talk a little bit about how that relates to the engine birth cohort study that was conducted. We used the cohort design to conduct an observational study where we created a quasi-experimental design where we were in engine Varettas and we matched it to a non-engine Varetta. So it allowed us to see how these two populations, which is engine-exposed population and a non-engine exposed population, we observed them through their pregnancies and down to the time the child turned 12 months of age. So we used a sort of a quasi-experimental approach and linked it to the observational study, and our outcome of interest was length for age, height for age, and stunting. And the aim was every single data point that was collected was aimed at generating evidence that would guide future policy. And just to give you an idea, and this is some of you have seen this for sure, but just to give you the breadth and scope of these kind of studies, this is the engine birth cohort study, and we had 7 time points of measurements. We went basically at enrollment when the mother was pregnant and when she had within 3 days after she gave birth, and then every 3 months after birth up to 12 months of age. And a key point that I wanted to point out was because we were comparing an engine population to a non-engine population, we had to estimate the sample size to make a comparison of these different groups, but we also had to account for attrition, which is one of the big issues, not just in RCTs, but also in cohort studies. So it's a fairly large sample size because of that. What we were very fortunate with was, in the last column, as you can see, is that we had such a well-implemented study that the attrition was very, very low, except in the last time point where we were at 80%. Most of the time, we were almost at 90% of our participation, which is a very high participation rate. And the importance of thinking through observational studies that are looking at a longer period of time is really illustrated in this graph, which is my last slide here, where this is essentially identified as a stunting syndrome by Andrew Prendergast and Jean Humphreys. They're working on in Zimbabwe on the SHINE trial. And I think they've illustrated this very well, where you can see that we tend to look at relationships in a linear fashion, but when it comes to stunting, it's actually a cyclical relationship. You go from neonates to 2 years of age, to school, to puberty and adults, and then you go back to conception. So when you're using study designs, it's really important. So when you're looking at when you're planning a study, it's really important to understand what your research question is. And in this case, if our research question is, as it was to understand what's happening in the first 2 years of life, it was really important to have a design that will allow us to not just address the first 2 years of life, but what was happening in pregnancy. Now, advantage of a lot of the times of these kind of studies, which I didn't bring up, and it's not in the advantages listed in any of them, is that particularly with cohort studies or RCTs, is that there is an opportunity, because they have been exposed to an intervention or because you have followed them over a period of time, at some point you as researchers might be able to go back to those households and collect data at a later time point, maybe when the children are in school or when they're adults. And there are some classical studies that have been done which have shown some very, very interesting results of early life interventions. And one of them is in Guatemala and called the INCAP studies, where they found the effect of the intervention of providing Incaparina, which is a complementary food to children. They found the effects of that in adulthood on work productivity and wages. So in the end, I think the point that I want to make here is that generating evidence is really important. We need a lot of data. We need surveillance, particularly for when you want to understand if you're meeting the nutrition targets or not. And it's really, really important to consider what your research question is when you're planning and implementing a study. Thank you so much, and I think we'll be open for questions.
The first question that we received is, in the nutrition and food system impact pathway, one of the impact is social equity impact. What does it mean?
In economic terms, people talk about winners and losers. And if you look at interventions generally, but agricultural interventions, early adopters tended to be less risk averse, et cetera. So in the food system, what that means is we're trying to provide access, quality across the food system, so you don't have winners and losers. I mean, the losers, in large part, tend to be lower income populations, sometimes certain subgroups, women and children. So looking at the food system as a way of delivering sustainable diets in a way that no one is left behind.
Can we do meta-analysis without systematic review, vice versa?
A meta-analysis generally is linked to a systematic review because you do have to go through the steps of identifying those articles and find the so in a way actually they go hand in hand. You can do a systematic review by itself without applying the statistical and analytical tools. So you can just do it. It's sort of a more systematic literature review. And then you add the meta-analysis to it. So I don't think that those can't do a meta-analysis without a systematic review. Wedge type allocation?
Yeah. Can you say something about wedge type allocation? Is it a design or?
Yes. So yes, I would have liked to go in a little bit more into sort of the experimental designs, and the wedge type is one of them, in which you essentially particularly on a programmatic application, what you can do is in your population, provide the intervention to one part of your population, whereas the other part serves as a comparison, and then you do a rollout once you have enough time to study or do the research on the differences between the two populations on a specific outcome. So the wedge type design is considered as an alternative to actually implementing a randomized controlled trial where you randomly assign individuals or communities or clusters to an intervention or not.
Next question is, what is the scope for real-time monitoring evaluation to generate evidence?
There is absolutely a lot of scope for monitoring and evaluation data to be used as evidence. The key thing is to ensure that your system is set up to generate the data. I'm not familiar with, I'm familiar with monitoring and evaluation frameworks, and I think that they are a very good system to, they are very robust. The question is if the data is actually collected against that framework. And if it is, then yes, it would be a very, very good source for generating evidence. As a researcher, obviously, then that goes into the realm of if you're using that data, it needs to be de-identified so that you're exempt from IRB. So there are those kind of technical issues to consider, but it definitely is a source. My key point would be is ensuring that the data that is being collected is of good quality and it's rigorously collected.
I'd like to add something there, and a specific example. In the late 1980s, I was working with the government of Malawi on a monitoring and evaluation system, and there was a mealybug infestation of the crop in northern Malawi, and the normal M&E wasn't picking it up, but feedback from relatives in the north to the capital said, we're being devastated, kids are dying. And so I think, getting back to your comment earlier about innovations, I think the experiential data is also important, where sometimes the quantitative data on a timely basis may not be indicating the nature of the situation. So I think you need to think, again, creatively about how you blend both.
Right. Yeah, and I'm sorry, I always have a quantitative hat on, but yes, you can actually also link your M&E to qualitative data collection, so you can have both qualitative and quantitative data that would contribute towards generating evidence. But this is one thing that we've been, at the Nutrition Innovation Lab, Patrick Webb and I would love to see M&E systems used more effectively, because there is a lot of data generated. I wouldn't know what the quality of the data is. If we can ensure that the quality is of the highest level, that data would be extremely valuable for answering programmatic questions, particularly implementation research questions.
Okay, the next question is, what would be the best method to generate evidence for this particular project?
Which question?
Growth through nutrition?
I assume.
Right. So I think the question I would have is generate evidence to answer what? So again, we sort of come back to what would be the question that needs to be answered relative to this project. Is it to determine if the project interventions are being implemented, so that would be an implementation research question, or is it to understand if the project has achieved its outcome?
Yeah, and if I could add, Shivani, I totally agree. I also think it's important to look at integration of components. I know the presentation on ag nutrition sounded a bit negative. It was not meant to be that way. There have been success stories in ag nutrition, but let me take one. Biofortification orange sweet potato, where not only did they adapt the cultivation, but vitamin A status of children improved. Now, the reason I point this out is that was not simply a standalone agricultural intervention. There was education of the mother on behavior change. There was income-generating activities for the mother. And there was a dose-response issue. Households and mothers who had more exposure, the effect was greater. So I think you need to look at all of these issues and not think of agriculture in isolation. And what's, I think, growth through nutrition, the overall framework is linking WASH, nutrition, agriculture, behavior change, and looking at exposure and what, at the continuum of these complement of activities, what do you see on various outcomes? Yes, stunting being one of them, but behavior change related to diet, behavior change related to WASH.
Next question is, what do you think is a more appropriate method to generate evidence regarding agriculture impact on nutrition?
Is it a method, or what would be the right outcome? That would be my question.
Well, let me just kind of, while somebody's answering Shivani's question, it really depends on how you're defining nutrition. I'm not meaning to be facetious. And I think part of the problem in the ag nutrition literature is the outcomes have been all over the map. If you have an intervention, say home gardens has been popular in some of what, for example, Marie Ruel in her meta-analysis analyzed. And why would you expect home gardens in the initial time period where you have your first harvest from a home garden, basically leafy green vegetables? Why would you expect that in a short period of time be related to anthropometric indicators in children? What you really should be looking at is did the nutrient density of the child's diet, if that's the objective of interest, change? Did overall consumption at the household level change? Did income change? So I think this gets back to defining what we mean by nutrition, and it's been a real frustration in the literature that nutrition is used very broadly without an identification of the specific metric that we need to use.
Yeah, and I think just to add on to what Eileen has just said, the issue that occurs when you're trying to link agriculture to nutrition is that it's a very long pathway. And if everybody is familiar with the UNICEF framework of the basic, underlying, and immediate causes, you should know that those are not causal pathways. Those are proposed pathways. And in that itself, you can see one of the issues is that it's really hard to measure that relationship from, say, poverty or even poverty alleviation because of agriculture to nutrition status of the child, because you could have so many other things that could confound that relationship. And for instance, if the child has diarrhea, if the child has ED, that's because it's poor wash, you can invest a lot in agriculture, but if with poor wash, you will land up with a lot of diarrhea and chronic inflammation that's not going to allow that child to thrive. And so I think one really needs to understand what the underlying biological issues are and think about looking at intermediate outcomes where, as Eileen had said, nutrient density, dietary diversity. Do these elements improve in these households? A key thing that we have been finding in some of our Asian studies, for instance, in Bangladesh, we have households where we're working in the Feed the Future zone of influence, and we have surveyed 3,000 households about 3 times, and they're all rural households. They're all farmers. 90% of them report having farming income, but all of them are as reliant on the market for their food as they are on their home production. So I think that that's also an element that needs to be considered within the context of agriculture to nutrition. And it's not just home-based production, it's also access to good quality food and produce in the market. It's very interesting that we find that whether it's vegetables or fruits or pulses or animal source foods, there is an equal reliance on household production and purchases from the market.
The other issue is, and I think it's how we measure some of these factors. Shivani and I were talking about this. In some work I did in southwestern Kenya, we found no relationship between having a latrine at the household level and child morbidity or child growth. When we were back to revisit this, and I put this in the area of delivery science, what we found was a disproportionate share of households that had latrines weren't using them. So we were asking the wrong question. It's not, do you have a latrine? Do you use it? And if not, why? And then getting at that context, which I think is where the what I call ethnographic data can be very helpful in explaining some of the quantitative findings that are being found.
Answering, did we get clarification? Answered our question. Okay. Are there any other questions?
Yes. Next question is that the hierarchy of evidence applies mainly for findings from quantitative. How do we systematically present qualitative?
Oh, yes. That is a very good question, and maybe that should be a topic for the next webinar. I don't know the answer. And you have some thoughts?
Well, yeah. I mean, I've been involved in a lot of qualitative work, but primarily in the U.S. And focus group type of work, ethnographic kind of work, which we never put forward as being representative, but it does look at issues through the lens of the intended beneficiary, and it's very helpful. The one challenge you have is, and I spoke about this early in the presentation, is that policy officials, finance kind of people, tend to be more persuaded by cost-effectiveness analysis. And the challenge with qualitative data, which can be very valuable, is how do you then merge that into a cost-effectiveness analysis to say, this works? And I think we need a lot more work on that.
So, and just, thinking this through from the perspective of the hierarchy of evidence, I think it's not as much as the hierarchy of evidence, because qualitative methods, you have key informants, you have focus group discussion, and essentially all the methods that you have, they really rely on the quality of the facilitator and the communicator. So it's really the person who's actually conducting these focus groups and key informant interviews that should be able to synthesize, and then whoever is going to be analyzing the data is able to find the pattern. So I would not put the qualitative methods into the kind of pyramid approach. I would you really have to take a qualitative approach to assess the quality of data that's coming from a qualitative study, because it's a very different lens you have to wear, and it's not something that I immediately put on because I work with so much quantitative data. The other thing that I feel is very important is qualitative data and quantitative data together. So like a mixed methods approach is a very, very good way of going. So it gives you the data that you need, as Eileen is saying, to support your qualitative findings with policymakers or people who are working in the ministries of finance. But at the same time, the qualitative data might actually help you understand why you are seeing something or not seeing something. So yeah, I think that would be my take on this.
How realistic is it to use evidence generated from a single study or project for policy advocacy?
It depends where you are in the cycle. I mean, that gets back to the question we posed: when is evidence enough? And I'll use an example from the U.S. Actually, let me use a vitamin A example. Where, so it's not so close to home. The original work out of Johns Hopkins, out of Indonesia, which suggested that vitamin A supplementation of preschoolers resulted in decreased mortality. There was a lot of disbelief because of that, but we've known for years that the vitamin A deficiency, if left untreated, was related to blindness. So that was not. But this was the first time back in the 90s there was a link between 80s and 90s, a link between vitamin A deficiency and mortality. And there was a lot of disbelief because it was the first study, the one study. What that generated was, some people dismissed it, but it generated, number one, an enormous amount of additional research on other studies, which eventually wound up in a systematic review, Beaton and Martorell, showing that on average, vitamin A supplementation decreased mortality by 23%. But another part that I think the rest of the story is, if you look at the Hopkins people, they were confident in their data, so they didn't just let it stand as one freestanding study. They actually used that information to advocate for increased funding for vitamin A research, but also vitamin A programs, and we know what's happened as a result of that. So, again, it depends, then, of course, year after year there was more data generated, but it's tough in the beginning where you have a single well-done study that might be suggestive, do you use it, or do you wait for more information? And I think it's, if you're confident in that piece of work, hopefully use it for advocacy in an appropriate way.